is part 2 of the principles of deformity correction. So we will basically just recap some of the basics that we discussed the previous time, and then mainly look at some case examples and some paper labs to try and make sure that everyone understands the concepts. So as we discussed last time, we've moved towards using the so-called apex axis method, that we try to simplify the terminology, and using this acronym of MAP the ABCs for our deformity analysis and planning. So there's also a little cheat sheet from Synthes that I think is also saved as a PDF on Dropbox. So there's really no excuse to not know all these angles. And basically, that's not only applicable to deformity analysis, as I've said before, or to deformity correction, as I said before. You cannot do any surgery in the lower limb with its trauma or arthroplasty if you don't know this by heart. So I'm basically going to assume tonight that everyone's up to speed with the basics that we discussed in the first lecture. Let's just quickly go over the definitions again. Let's start with the anatomical axis. Bijou, you're first on my screen here. Can you tell me what's the definition of the anatomical axis of a limb segment?
Hi, Prof. So the anatomical axis goes from along the border of the femur through the center of the knee down the middle shaft of the tibia.
Yes, so it's basically the intramedullary axis of a long bone, and mechanical axis then on the other hand.
So that goes through the center of the femoral head to the center of the knee, and then down to the center of the ankle.
Yeah, so mechanical axis can be both for a limb segment or for a overall limb. So basically, mechanical axis of your lower limb would be the middle of your hip to the middle of your ankle. Mechanical axis of an individual segment, let's say the femur, would be middle of the femur to middle of the knee. So it's basically from the middle of the joint to the middle of another joint. And there's just a graphic sort of representation, as you can see here. The red axis is the overall mechanical axis of the limb, so middle of the hip to middle of the ankle. In a normal aligned limb, that would coincide with the mechanical axis of the femur, which is middle of the hip to middle of the knee, and mechanical axis of the tibia, which is middle of the knee to middle of the ankle. But in a deformed limb, this can be different. You see in this valgus knee, the overall mechanical axis passes lateral to the knee, but then the mechanical axis of the femoral segment is middle of the hip to middle of the knee, and then the mechanical axis of the tibia is middle of the knee to middle of the ankle. Joint angles. This is then the angle of your joint in relation to the axes, whether it's anatomical or mechanical. So you can have your conventional joint angles with the anatomical axis, as we see here, and your conventional joint angles with the mechanical axis. If you're confused of which angle to use, specifically if you look at the knee here, by definition, we use the angle at a joint when normal is less than 90. So that's why in the femur we use the lateral distal femoral angle, and in the tibia we use the medial proximal tibial angle. Lateral distal tibial angle was just below 90. The proximal femur, there's a variety of angles used. Actually, the lateral proximal femoral angle that they note here is very variable because of the variable shape of the greater trochanter. So in the proximal femur, the most accurate measure to use is the neck shaft angle. So here is just the mechanical axis on the right with the mechanical axis angle and the anatomical axis angles on the left. The main difference is around the knee and the proximal, in the distal femur, where the mechanical lateral distal femoral angle normal is 87 degrees, and the anatomical lateral distal femoral angle is 81 degrees. So, Brad, you next on my screen here, can you tell me where is this difference relevant? The difference between the anatomical and the mechanical lateral distal femoral angle.
Prof, that's in a knee replacement if you're doing intramedullary femoral referencing.
Yeah, so just explain that to the others.
So if you're trying to construct someone's knee, you're normally planning with the mechanical axis, but in the femur, we'll traditionally use an intramedullary rod in the femur. So then you need to build in normally that 6 degrees into your femoral cut, the difference between anatomical and mechanical axis.
Knee replacement, if you want to do mechanical axis alignment rather than kinematic alignment, you want to cut your distal femur perpendicular to the mechanical axis, but you reference through intramedullary. So you put an intramedullary rod up the femur and you attach your cutting blocks to that. So you can't cut 90 degrees to that. You need a 6 degree valgus cut to the anatomical axis to cut perpendicular to the mechanical axis of the femur. Okay, and then the next definition of mechanical axis deviation, which is just a way to quantify how abnormal a mechanical axis is, and we measure this in millimeters from the middle of the joint, and then the apex of the deformity, or we previously referred to as the cora, which is where the axes of the two deformed segments meet. So this is the where two axes meet is called the apex. And the correction level is basically a line that bisects the greater angle at the apex, and anywhere on this correction level where you place a pin that you will do your correction around, will you get a correction of your deformity. So if you place your hinge here, you do an osteotomy there, and you center your correction around this hinge point, and see that you will correct the deformity with some lengthening. If you do it on the other side of the deformity, it will be with some shortening. The hinge point is the point where you center your correction around. So when we do deformity planning, we can use either anatomical or mechanical axis planning, and we'll discuss a little bit more about that later and what I use when. So to just basically go over the steps again. So map your ABCs. M is for measure your mechanical axis deviation. A is for analyze the joint angles. P is for pick the deformed bone. A is for determine the apex of the deformity. B is for choose your bone cut or the level of your osteotomy. And C is to plan your correction, whether that's gradual or acute. So this is just a case in practice, a little paper lab. So if we go step by step on this deformity, you can see here we've drawn the overall mechanical axis of the limb, you can see that there's an abnormality in the mechanical axis. So the mechanical axis deviation is X millimeters, varus, because it's toward the midline. Important now, because it always creates confusion. Now you want to erase or delete that mechanical axis of the overall limb. Now you draw the mechanical axis of the individual limb segments. So you draw an axis of the middle of the femur to the middle of the knee, and in the middle of the knee to the middle of the ankle. And now you measure your anatomical, your mechanical, your joint angles with the mechanical axis. Here, your mechanical lateral distal femoral angle is 87 degrees. That is normal. Don't forget to measure your neck shaft angle in the proximal femur, which is also normal in this case. In the tibia, the medial proximal tibial angle is 74 degrees. And don't forget to measure the lateral distal tibial angle. So the next step is pick the deformed bone, while the mechanical medial proximal tibial angle is abnormal. So the deformity is in the tibia. Now you want to determine where in the tibia is the apex of the deformity. And how you do that? Well, again, you erase your previous lines. Now you want to draw the axis of the individual limb segment. So for the proximal tibia, you can do one or two things. Because the adjacent limb segment, the femur here, in this case is normal, the mechanical axis of the proximal part of the tibia should just be a continuation of the femoral mechanical axis. The mechanical axis of the distal tibia is basically a continuation of the lateral distal tibial angle, which is 89 degrees, and where these two intersect is the apex of your deformity. If you don't have a normal, you don't have long leg views, or you don't have a normal adjacent limb segment, you can also draw the axis of the proximal part of your tibia by just dropping this line at 87 degrees from the joint line, which is the population normal. So that gives you the apex, or previously known as the cora. Is everyone with me on that simple paper lab? Please ask me if there's any questions.
Can you just go one slide back, Maritz?
Yes, sure.
Sorry, it just looked like the two dots that they drew in a different place, but if you compare the second last and last examples, but I think that other dot is just the center of the joint or something.
Yeah. That was just the center of the joint where they draw. This is where they determined the apex. Yeah. Okay. Good. So the next concept is the concept of osteotomy rules. Now, for me, the terminology here has always been a little bit confusing because it's really just osteotomy options rather than osteotomy rules. But, you know, this is what Drew Paley called it. So osteotomy rule number one, or the first option, is the one that is ideal. And that's where we do our osteotomy at the apex of the deformity. So at where the two axes meet, we do our osteotomy, and we send our correction around that point, which is the hinge point. And what will happen in practice, we will get a correction of our axes without any translation. I'll show an example now. Often this is not possible, and I'll show some examples just now. And then we have to do our osteotomy away from the apex of the bone, apex of the deformity, but we still hinge our correction around the apex. So this means we will correct the overall axis of the limb, but we'll do it with some translation. And the reason why we have to do osteotomy away from the axis is, well, if the apex is close to a joint, for instance, let's think of Blount's, the apex is always very close to the knee joint. In whether you do gradual correction with a frame or acute correction with a plate, you cannot get adequate fixation in the very short epiphyseal segment if you do your osteotomy at the apex. So you would do your osteotomy away from the apex, but that means you have to introduce some translation. And osteotomy rule number 3, or option number 3, is the one that we always avoid. And this is where our osteotomy is away from the apex, and we also hinge our correction at a point away from the apex. There's some instances in the lower limb where this is unavoidable, and we would still do it, but as a general rule, we try and avoid it. It's something that mostly we'll see acceptable in the upper limb. We see in the upper limb is different because it's not weight bearing, so the overall axis of the limb is not important. So osteotomy rule number 1 in practice, here you can see there's the axis of your proximal segment, there's the axis of your distal segment. Where they intersect is the apex of the deformity. If you do your osteotomy at that level and you center your correction around that point, so you place your pin at that point, you will correct your alignment by opening wedge, closing wedge, or opening, closing wedge, which is not always practically possible. When you're unable to follow osteotomy rule number 1, you usually aim for osteotomy rule number 2. Now let's imagine this deformity, but you've got a joint very close to it. So in other words, there's not enough space for fixation in this segment if you do your osteotomy at the apex. So here you would do your osteotomy away from the apex, but importantly, you still place your pin at the apex of the deformity. You will correct this deformity with translation, as you can see on the right, but you'll correct the overall alignment of the limb. So this translation doesn't matter. Just if the translation is so big that you're completely off in the bone, you can sometimes have healing problems. So it is something to be conscious of, that you want to do the osteotomy as close to the apex as possible. And the osteotomy rule number 3 is the one that we always try and avoid. This is again where, let's think of Blount's, and we say you've got a knee joint here. There's the apex of your deformity, but you can only do your osteotomy away from the apex. But now you still place your hinge at the osteotomy. So here you can see, even though you correct the angulation, in other words, the axis of the proximal segment and the distal segment is parallel, overall there's still translation. So overall, so there'll be a deformity if you connect the joint above and the joint below. Everyone happy with the concepts of the osteotomy rules?
Yeah, all good.
Yeah, got it.
Okay, so as I said, osteotomy deformity analysis and the osteotomy rules are not only important for limb reconstruction or deformity correction. Here you can see a very bad case of late presenting infantile Blount's with multiple surgeries and double elevating osteotomies, acceptable limb alignment. But it can also be important in many other fields of orthopedics. So if you look at this knee x-ray, maybe let's Dane, you answered a similar question today in the 1 o'clock meeting. What would be your, you could skip past all the non-operative stuff, but what would be your treatment in a case like this?
The x-ray shows essentially bone-on-bone arthritis, more so in the medial compartment of that knee. So, I don't know the patient's history, obviously, but I think we're heading towards a total knee arthroplasty.
Okay, good. Any more information that you would like?
Yeah, there's a lot, I suppose, but in terms of deformity planning, we can assume that that white line is the mechanical axis, so we can see the overall alignment is in varus. So you're going to have to factor that in when you are doing your deformity correction. So Brad's already mentioned how we referenced the femur with intramedullary, and you have to compensate for that. Now the overall limb alignment is in valgus, so you're going to want to, varus, so you're going to want to restore that alignment at the end of your cutting and trialing. So you just need to factor that in with your cuts and your placement of your tibial and femoral components.
Yeah, so basically if the varus is just due to bone loss from the loss of cartilage there, or not bone loss but cartilage loss, so the loss in joint space there, then like you say, you can build that in. But what if I show you the next x-ray? Does that change things?
Yeah, so there's a significant deformity in that femur, which is most likely resulted in that joint degeneration. So not sure if this would be something that you would sort of stage and first correct the deformity in the femur and then proceed to reevaluate the knee and see if unloading it in that way does relieve some symptoms, or if you need to proceed with arthroplasty as well. But yeah,
so basically the knee here likely is too far gone for an osteotomy to give relief. But however, if you're going to intramedullary reference here and just cut 6 degrees to it, you're still going to have a significant deformity, because there's a deformity in the shaft. So you know, you should just have a different strategy here, and that could include either as a general rule, diaphyseal deformities you should correct before you do a joint replacement, because we see, especially in a younger, higher demand patient, because otherwise overall poor alignment would affect your joint replacement. If you think about it also, if you do the correction here in the joint, it is very far away from the apex, and it won't be possible to correct it completely. Or you should have another strategy and, you know, not use intramedullary referencing if you want to correct that. But this would probably be take very abnormal bony cuts to correct this deformity in the joint when you do a knee replacement. So in this case, rather osteotomy and correct the deformity. There was also a sagittal plane deformity. I helped one of our knee colleagues with that, and then the overall alignment obviously is not normal still, because there is bone loss, but now the diaphyseal deformity is corrected, and you can use a sort of standard technique for a knee replacement. What about this case? Skulk, is deformity analysis important in this case? Let's say you want to do a retrograde nail for that fracture on the right.
Yes, it will be important, but you can't pre-operatively, you can't really assess the anatomical axis, also because you don't have the bilateral femur fractures, so it will be quite difficult to be able to plan. But intraoperatively, you'll have to make sure that you, if you're doing a retrograde nail, that you have your 81 degrees of your anatomical lateral distal femoral angle correct, and that you have your rotation corrected, or you don't have a rotational deformity, and you can do that intraoperatively or using fluoroscopy and maybe measuring the mechanical axis intraoperatively with either maybe using the diathermy cord or just using the joint line and the anatomical axis to calculate it on your fluoroscopy. But it will be a tough case. So I think
I think obviously when you have such a comminuted fracture, you can't use sort of anatomical reduction to guide your alignment of the limb. So you need to use your joint orientation angles. So if you basically start your retrograde nail with a 81 degree takeoff of the femoral distal, femoral condyles, and you push your nail into the proximal shaft, you should correct the alignment here. So basically, if you look here, retrograde nail blocking screw to make sure don't go, and then up valgus, and then over, and then up the canal, and then your overall limb alignment is restored. And then again, as I said, arthroplasty case, so slightly different from the other case that I saw. So here you can see from the long leg views that there's obviously overall gross valgus, but this valgus is mostly, well, it's all in the joint due to bone loss. So in this case, it can be corrected in the joint. And in this case, because of the attenuation of the medial structures, and you can see how the medial joint line opens there on the long leg views, it needs a higher degree of constraint with a knee replacement, as you can see there. Okay, so to go back to the paper labs, if we look at this tibial deformity, so in general, I use mechanical access planning. I'll tell you guys now about the exceptions, or where we would use anatomical access planning. In the tibia, the anatomical mechanical access is basically parallel. So you can, they basically interchangeable. So if we look at this case, again, overall axis of the limb, the mechanical axis deviation is medial by X. So there's various malalignment of this limb. If I draw the mechanical axis then of the individual limb segments, I'll see that the medial proximal tibial angle is abnormal. So the deformed bone is the tibia. Draw the mechanical axis of the proximal part of the tibia, and then the mechanical axis of the distal part of the tibia, and where they intersect is the apex. Okay, so just to show you guys now, when you use mechanical axis planning in the femur, it's slightly more complex. So let's look at this case. So you can see here that I've drawn the overall mechanical axis of the limb, which shows a mechanical axis deviation towards the midline, so varus malalignment. If I draw the mechanical axis now of the individual limb segments, and I measure my joint angles, don't forget your neck shaft angle proximally and your lateral distal tibial angle, which are normal in this case. And I look at my medial proximal tibial angle, and that's normal, but my mechanical lateral distal femoral angle is 107 degrees, and it should be 87. So there is a deformity in the femur. Now I want to determine the apex of the deformity in the femur. Using mechanical axis planning, it's easy to draw the mechanical axis of the distal part of the femur. Just like with the tibia, because the adjacent limb segment or the tibia is normal, I can just continue the mechanical axis of the tibia. Or if I don't have long leg views or the adjacent segment is not normal, I can draw this blue line at 87 degrees of the joint line. Now comes the difficulty. Where do I draw the mechanical axis at the proximal part of the femur? So this is the most accurate way to do it, and this is to reference the mechanical axis of the anatomical axis. So the first step is to draw the anatomical axis of the femur. That's just an intramedullary line. Now I move that line parallel going through the middle of the femoral head, and then I draw a line at 6 degrees from the mechanical axis, because that's the difference between the two. And then where these two intersect, that's the apex of the deformity. Now this is quite confusing, and it's a lot of lines. The alternative, so there's two different techniques to determine the mechanical axis of the proximal femur. The one is the one that I just showed, which is accurate, but quite a few steps. The other one is using the mechanical lateral proximal femoral angle, which is a line from the GT to the middle of the femoral head, dropping down a line at 90 degrees. Now that looks very simple in practice, but unfortunately this angle is grossly inaccurate because there's such variation of the shape of the GT. So unfortunately we can't use this. So what I do is, once I determine that the deformity is in the femur, I determine the apex using anatomical axis planning in the femur, which is much simpler. So if we go to the steps, and how you determine is very simple. The proximal axis, anatomical axis, is very easy because that's just an intramedullary line, and the anatomical axis of the distal part of the femur, you can use the population normal. Now it's just important now that you use 81 degrees and not 87, because you use the anatomical axis proximally. So within the limb segment, so within the femur, you need to use the same axis, proximal and distal. So my approach to the femur is I use mechanical axis planning up to pick the deformed bone. If the deformed bone is in the femur, as you can see here, if the deformed bone is the femur, because the mechanical lateral distal femoral angle is abnormal, it's 96 and should be 87, then I delete these lines and I find the apex using the anatomical axis. And that's very simple. I just draw the anatomical axis of the proximal part of the femur, which is an intramedullary line, and I draw the anatomical axis of the distal segment of the femur, which is 81 degrees from the joint angle. Is everyone with me there? Any questions?
Why can't you just use anatomical referencing for that segment from the start?
Yeah, so basically, if you cannot draw an anatomical axis of a whole limb, so you have to start with the mechanical axis. You could do that for the femur. So let's say now you step one, you draw the mechanical axis of the whole. Let's go back to this femoral case. Femoral mechanical axis planning. Okay, you have to draw the mechanical axis to determine whether there is a deformity. Okay, now you want to draw your axis to look which segment is abnormal. You could do anatomical axis planning here. Then you need to draw your anatomical axis down the femur and measure the anatomical lateral distal femoral angle, which will still be abnormal, and in the tibia the two are parallel. So you could, after this first step, just use anatomical axis planning. Then you must remember that you must just compare this to 81 and not to 87 degrees. So that would be acceptable as long as you understand what you're doing. Does that answer your question?
Yeah.
Dan?
Yeah, sorry, it does. Can you hear me?
Okay, cool. Yeah. But the first step, because by definition, you cannot. There's no anatomical axis of a whole limb. So to see whether there is an overall malalignment, you have to start with the mechanical axis.
Got it. Thank you.
Any other questions? Okay, and these are quite difficult concepts. It's one, before Zoom, this was actually something that from before my days, we always did as a paper lab. So Stuart always used to give this stat with actual papers and goniometers and pencils, and it's actually very good to practice it. So it's a bit harder to just explain the concepts without practicing yourself. We're going to look at some examples and discuss some examples so you can learn from other people's mistake, but in reality, the best is still to practice. So any case that you see with a sort of deformity, just run through the steps. It might be obvious where the deformity is, but if you just go through the steps every single time, then it will become sort of second nature. So let's look at a complex limb deformity case now. This is a 16-year-old boy with adolescent plants that presents with a progressive deformity of his left leg, completely asymptomatic. So he's got junoverum and an increase increase BMI. This is the lateral of his, and this is the lateral of his tibia. So I've asked Dane and Francis to prepare some cases. So I'm just going to run through this one so you guys can see how I would do it. And then we'll look at the others later. So if we start at the first step, so the M is to measure the mechanical axis deviation. You can see that there's an abnormal alignment of both limbs. If you think back of last week's stats, I would say on the right side, the mechanical axis deviation is 15 millimeters. It's outside population normal, which is 10 either side of the center of the joint, but is completely asymptomatic. And I probably won't treat him because it's a very minor deformity. If he was symptomatic, and that is he had medial joint pain, early OA, meniscal tear on the medial side, or some lateral pain from attenuation of the soft tissue, then I think you can treat him. But in a completely asymptomatic patient, there's no clear benefit that correcting this deformity to population average would be to his benefits. On the left, though, there's a gross deformity. So even if someone is completely asymptomatic, you obviously can't force him, but I would strongly encourage deformity correction. And here you can see the mechanical axis deviation is 106. So there's a big deformity. The axis is completely outside the joint. So step 2 is we want to analyze the joint angles. So here we measure our mechanical lateral distal femoral angle as 98, mechanical proximal tibial angle, mechanical medial proximal tibial angle is 70, neck shelf angle is normal, lateral distal tibial angle is normal, varus angle of the limb is 28 degrees. So in other words, here, both the femur and the tibia is abnormal because the mechanical lateral distal femoral angle and the medial proximal tibial angle are both abnormal. Don't forget the sagittal plane. As you can see here, the angle we measure around the knee is your posterior proximal tibial angle. So this angle here. And normal is 81 degrees. In other words, in a normal joint, the proximal tibia has a 9-degree posterior slope. And this joint has a 20-degree posterior slope. So there's an apex anterior deformity close to the joint. So here you can see pictodeformed bone, step 3, while both the femur and the tibia are deformed because the mechanical lateral distal femoral angle is 98, should be 87, and the medial proximal tibial angle is 70 degrees. Normal neck shelf angle, normal lateral distal tibial angle. So both the femur and the tibia is abnormal. Let's start with the femur. So now I want to determine the apex of the deformity in the femur. So now I'm going to use anatomical axis planning because it's easier. So I draw the anatomical axis of the proximal femur, which is an intramedullary line. I draw the anatomical axis of the distal femur, which is my joint line. And then remember, 81 degrees, not 87, because I'm using anatomical. And that's the apex of my deformity in the femur. Now I'm going to do the same in my tibia. I draw the mechanical axis, or anatomical axis was the same, the proximal tibia. So that's 87 degrees of the joint on the medial side, because remember now my adjacent limb segment is also abnormal. And this the axis of the distal segment and where they intersect is the apex of the tibia. I'm going to plan my bone cut, so I'm going to choose my osteotomy level in the femur and the tibia, and then I'm going to plan my correction, whether it's going to be acute or chronic. So what to do with the right leg, as I said, I'm not going to do anything because it's a very minor deformity. Also in adolescent Blount's case, because they have usually often very big, they have the so-called fat thigh gait. Actually, a little bit of varus is almost preferred, because if they're completely neutral or valgus, they don't do well actually, because they literally can't clear their legs when they walk. So in this case, there's still some growth left. If you could see, look at the open physis in the distal femur. So elected on a gradual correction using guided growth in the distal femur, and for the tibia, osteotomy with a gradual correction with the use of a frame. This is the x-rays at the end of correction. You can still see a little bit of residual varus because we've only corrected the tibia to normal. There's still a deformity in the femur, and then we hope that that would correct with the guided growth. Usually aim to make patients symmetrical, especially if they're asymptomatic. So we, we'll want to make them similar as on the other side. This is post-correction, as you can see, and see osteotomy rule number 2, because there's some translation at the osteotomy. I don't know for you, we recently discussed the Blanche case in the M&M. You can see here, because it's a big child and all the fixation is in a single plane. So 3 wires, including 1 olive from each side and 2 half pins, all in a very narrow zone, and an osteotomy that's still metaphyseal for adequate fixation. And this is him at the end of correction with similar mechanical axis, and might still get a little bit of correction in this distal femur. Anyone notice anything on this long leg view?
A bit short on the left.
Yeah, who's that? Skulk. Yeah, so it's quite unusual in a normal limb that, if you look at the physis distal open, looks like despite just an 8 plate on the lateral side, he's had some premature physeal closure on the left distal femur, and he has significant shortening on this side, even though his overall alignment is now is corrected. You can see then quite a big discrepancy, 55 millimeters. Possibly something if we, it's in the femur as well. If you can see his tibias at the same line, if we sort of saw it when we do the correction. Now we had a frame on his leg. If you just lengthen him in his tibia 55 millimeters, he'll have a very asymmetrical knee height, which can also cause some problems. So we elected to wait till everything is healed and it's skeletally mature, and then did a precise lengthening for him proximal femur. That is eventually his leg length is restored, and his overall alignment is the same as the other side. Any questions?
Yes, Prof, can I ask?
Yeah, sure.
So, length discrepancies, we sort of use that mark of about 2 centimeters. That's quite well tolerated. I've just seen in quite a few of our sort of Blount's cases and other cases, there's often a deformity in both bones, femur and tibia, but we choose to not address the femur if there's a small enough deformity. Do you have sort of a guideline of how much you would allow and how much, or when you would start addressing it?
Yeah, that's a very good question. Specifically in adolescent Blount's, the deformity is usually symmetrical, so it's almost equal varus in the femur and in the distal in the distal femur and the proximal tibia. So I always say, like, if there was a tablet for correcting a deformity, we would treat everyone. But because it's quite a major intervention, we have a higher cutoff. So I think for me, if an adjacent limb segment has a deformity of less than 5 degrees, it doesn't justify a separate osteotomy. So if you look at this case, if the big varus in the tibia and the femur is 4 or up to 5 degrees abnormal, then I would be happy to slightly overcorrect the tibia to correct the overall malalignment, because a slight oblique joint line of less than 5 degrees is not really proven to be a problem. Once the deformity in the adjacent limb segment is more than 5 degrees, if you leave him uncorrected, that will still be a significant deformity. or if you overcorrect, that will give a significant oblique joint line. So for me, 5 is the cutoff. If the deformity in the adjacent segment is more than 5, it needs a separate osteotomy or guided growth or whatever technique you use to address it. When it comes to leg length discrepancies, and specifically Blount's, can be very difficult because especially if it's bilateral deformities and they're not symmetrical. With correcting angulation, you get a minimum amount of lengthening, because basically the shortening is really apparent. So I always do the most severe side first. So let's look at this case. I would do the left side first. I would correct the leg, not lengthening at all. So in other words, I would just correct it, but by just straightening the leg, I would achieve X centimeter of lengthening. When I do the less severe side, then I can correct it and lengthen it to match the other side. Because if you do the less severe side first, then you just correct it, then you've straightened the leg. But if you then do the severe side second, you might lengthen it more than the other side. So when it comes to leg length, I usually do the most. When it comes to deformity correction, where it's bilateral, I usually do the most severe side first, because that allows me to match the leg length when I do the less severe side by over lengthening a little bit. And then again, I think 2 centimeters is the measure that's used in the literature. Even after 1 centimeter, there's some abnormalities shown in gait analysis. But again, obviously an osteotomy and leg lengthening is quite a severe treatment. So we usually use 2 centimeters as a cutoff. But I have done in select cases smaller lengthenings of like 15 millimeters, and someone that's well informed. If you think about it, if you walk with with a shoe on your one foot and without a shoe on the other foot, it does not feel normal, So, but obviously that can easily be corrected with an insole. So we usually use 2 as a cutoff, although you can do shorter lengthenings in select cases. Does that answer your question? Cool. So I want to just jump forward to another case. This is now more of a lengthening case. So just sort of out of interest, a patient, this was his initial injury. I don't think any of you have been around long enough to remember this case from Red Cross, but there's a young boy. If you look at that first low locks on the left, that was a pedestrian car, and he came with bilateral hip dislocation, so an anterior dislocation on the right, which is obviously unusual, and then a central locked dislocation on the left that was irreducible. If you look at that 3D recon view, you can see that that's an avulsion of his greater trochanter. So it required an open reduction and then fixation of the greater trochanter. But unfortunately, despite this, he developed AVN and complete collapse of his hip on the left, and had this presented with this deformity. If you look at his long leg view here, he had a very large leg length discrepancy, partly due to proximal migration of his femur from the AVN, but mostly because of a large adduction deformity at his hip. So his leg was so adducted that it gave a significant 50-degree adduction deformity. So it gave a very significant further apparent shortening of this limb, and then also a 60-degree fixed flexion deformity of his hip. So he really had a terrible gait. He could barely walk. So in his pre-op assessment, now, the traditional teaching when it comes to lengthening is that you should first stabilize the joint above or the joint below. But if a joint is so stiff, you can say this hip is unstable, that there's no movement, you could lengthen without stabilizing the hip. And you can see here these 2 x-rays in the pre-op assessment. It's called This one is just a this AP standing, long leg view. So it's a pelvis AP standing on both feet. And the one on the far right is what's called the flamingo view. So this is him standing on his left leg, so the short leg only. And that you can see that there's no further adduction, or so his pelvis does not further drop away. In other words, this hip is so stiff that there's no movement. So you could lengthen him without doing anything to the hip first. He had no pain in his hip. His symptoms were terrible gait and some, lower back pain. So with him, we did a sort of a variation of the so-called pelvic support osteotomy, which is a valgus extension osteotomy on the proximal femur, so that the apex here abuts on the ischial tuberosity, and it places his hip in a functional position, basically in the orthodesis position. So 20 to 30 degrees of flexion. So you can ambulate with your lumbar spine mobility, 5 degrees of adduction, and 5 to 10 degrees of external rotation, aiming for a minor leg length discrepancy because of the stiff hip, and then a retrograde precise. All these blocking screws are just to create a canal to lengthen without introducing a deformity, and then lengthened his femur 60 centimeters. So you can see there that at the end of his lengthening, he has a almost equal leg length, except for 10 or 15 millimeters, and very, very much improved gait, and basically a functional hip orthodesis with that stiff hip. Good. So before we look at the other cases, basically, we're just going over the basics and some examples first. Is there any questions for me? Because before we ask Dane and Francis to show the cases that they prepared. No questions. Okay. So who wants to go first? Dane, Francis, and this is not a. You're going to say this is not an exam. The whole goal is to just show us what you've done, and it's for everyone to learn. And if there's somewhere where you're stuck or something you've done wrong, then I'll correct you along the way. Who wants to go first?
Yeah, I don't mind.
Okay, go for it. Do you want to share your screen?
Can everyone see my screen?
Yes, I can see as well.
Okay, so these x-rays belong to a 13-year-old girl who's otherwise well, presented complaining of medial-sided knee pain and ankle pain, and basically worried about cosmetic deformity more than anything else. So this is her long leg views. I just focus on the right leg, although the deformity is bilateral. So drawing the mechanical axis view, or line rather, to start, you can see that the line passes lateral to the knee, implying valgus deformity. So measured that at about 4.5 centimeters, 42 millimeters. Proceeded to measure the neck shaft angle, which was roughly normal at 126. And then I measured the anatomical axis of the femur, so that should be 81, and I got just about that, 80.6. Then I also measured the joint convergence angles, which I got 3 degrees. It should be 2. And then measured her joint angles on the coronal sagittal plane as well, which were both normal for the distal femur and proximal tibia. And we'll get to the problem. So the medial proximal tibial angle should be 87 degrees, and we've got 104. And then the lateral distal tibial angle is essentially normal at 89. So it tells you that the deformity is in the proximal tibia. Then measured where those two joint angles converge or cross, where the apex is in the tibia. In this case, it's quite well, proximal metaphyseal tibia. And then I quantified the magnitude of that deformity at about 17 degrees. So the deformity is in the proximal tibia. It's a valgus deformity, magnitude of about 17 degrees. Surgical planning in this case, there's a couple of options. Her physes are still open. She's 12 years old, so you could, in theory, go for guided growth corrections. Alternatively, more definitive corrections could be done with a frame. I believe that there's enough proximal tibia available for fixation proximally to that. If you stick to your osteotomy rules, you could apply rule number 1 and do the correction at the deformity in this case. And you could debate whether or not you could actually even fit a plate there and do an acute correction with a medial closing wedge. She is 12, so you could, debate how much growth she actually has left, and you can get screws, close to the physis if you decided to do that. But you would just discuss with the patient, I suppose, what options they chose or would prefer rather. But in this case, ultimately, what we did was guided growth for her.
Yeah, perfect. That's excellent. So it's basically all the steps correct. I think one thing that's good that you mentioned it, that we often skip across, so joint convergence angle, in other words, around the knee, the difference between your tibia and your distal femur. We sort of assume most of the time that those are parallel, but actually it can be divergent up to 2 degrees. So that's also important to look at. In sort of normal appearing one, we usually assume that they are parallel, but in some cases like that knee I showed earlier, where you have a deformity and some instability, they can be grossly abnormal, and then it interferes with your analysis. Also with that sagittal plane, like you said, very important, the posterior proximal tibial angle, but then also the femur, the distal femur. Obviously, the distal femur, the angle's a little bit more difficult to draw because there's no flat surface in the distal femur, articular surface. So we usually use a measure which is the physeal scar, or the sort of physeal line, which is at the back of Blumenstadt's line there to the physis in the front, and with the anatomical axis. And that's also 80, the normal is also 80 degrees. Yeah, so that's basically perfect. That's just what would be expected of you in an exam situation to break it up. Does anyone have any questions for Dane or questions around Dane's case? So use anatomical axis analysis in the femur, which is absolutely fine. Like I said, that's simplified. And yeah.
Thank you.
Cool. Francis, do you want to? Yeah.
Sorry, Dan, if you can just go back one slide again of the femur where you calculated the angles. Yeah, I mean, the lateral distal femoral angle that you've calculated there doesn't really go through the diaphysis. So it looks like there is a diaphyseal deformity of the femur as well.
So maybe I can just answer here. So that's the problem with using the anatomical axis, because that's an intramedullary line. So in this case, if you did your mechanical axis here, you'll probably find a minor femoral deformity because there's a slight bowing of the femur. So that's the sort of inaccuracy of an anatomical axis, because basically, you cannot draw a straight line here through the whole femur, and that's why I said I usually only use the anatomical axis one step further on, and that's to determine the apex. So here, I would measure like Dane's measuring now, the lateral distal femoral angle, mechanical lateral distal femoral angle, which possibly with that little bit of bowing, there might be a very minor femoral deformity, but in a straight femur should have the same answer. But you can see that this femur is almost a little bit banana shaped, basically.
So then, on the corollary to what Raymond said, if you reference mechanical axis then, and the femur was like a full-on S shape, you would also then potentially ignore, the axis might be fine. And is that, I suppose, is that all that matters?
Absolutely. So you should always look at both. So basically in like a S-shaped, where there's a combination of translation and angulation. Even in trauma, you can have a normal mechanical axis, but gross deformities. So you should always basically look at both. If there's obviously an obvious deformity, so we see it in some soft bone conditions where you have I'm just trying to think. I've got a couple of cases where there's such a sort of S shape in the leg that the overall mechanical axis is normal, but then there's such a big deformity in the tibia, or sometimes two deformities in the same bone, they sort of cancel one another out. So how can I say, this is just also very oversimplifying. So usually the clue in those cases is when you do your deformity analysis and you do your proximal segment of the limb axis and your distal segment, and they intersect outside the bone, then there's two deformities. Because what we're trying to do is to explain every deformity by a single apex. We're obviously, so if you read Draw Paley's book, what we've covered tonight is maybe the first 50 or 100 pages of 800, because basically everything we've done is just looking at tibia and femur uniapical deformities, and there are many deformities that's multi-apical. And the clue to a multi-apical deformity is that if your distal femur or your distal limb, the distal segment axis and the proximal segment axis meet outside the bone, then that tells you there's more than one deformity in the limb. Does that make sense?
Yes.
Cool. Francis, do you want to share your case?
Sorry, can I just ask one more question as well?
Yes. Who's that? Sorry, I missed. Who was that? Just asking a question. Sorry, no, nothing came up on my screen.
Samsung, bro.
Please, Dama, I'm using my phone.
Okay, cool.
It's just looking at Dane's case again.
Yes.
Hypothetically speaking, if we used a high tibial osteotomy instead of guided growth, I just wanted to clarify what the transverse bisector line of where the osteotomy is. So I think he measured 17 degrees, I think, where his apex was. I just wanted to, Dan, if you can just share your screen again. So then when you minus that from 180 and then you divide it by 2, you get 81.5. So then do you just measure that angle from the apex, and then that's essentially where your osteotomy line will be on the actual apex? If you get what I'm saying, Prof. Oh no, my connection's bad.
I heard you, Zama. I think Maritz connection might be gone.
Oh, I thought it was mine. I was like, what?
Your
Okay, Dane, you can answer then. I just wanted to double check.
Maritz he's so busy rubbing his face, he had to go off there.
Oh, okay.
Are you asking if the apex of the deformity angle that you measure needs to be factored into the angles that you measure at the joint line?
No, I think that's what I'm saying. But essentially, you know, okay, look, where am I now? I'm at the maps ABC part where we're at the apex. So we've drawn where our deformity is. We're now our apex is where we're going to cut the bone now. And essentially, where we make the cuts, we have to calculate that transverse bisector line. Because essentially, when you have those lines crossing, you then measure that angle, and then you subtract it from 180 and you divide it by 2. Isn't that's part of the how you decide where to make your cut?
Yeah, so I mean, you can use that for your osteotomy planning and deciding where you're going to put your hinge along that line.
So if you want to purely do an opening or a closing wedge osteotomy and to open or close as little as possible, yes. So you basically, because obviously the apex is in the middle of the bone, and now you want to take that to the cortex. So then you would draw what you used to call your transverse bisector line or your correction level, and then where that intersects the cortex, that's basically where you would do your osteotomy.
Yeah, okay.
Does that answer your question?
Yeah.
Okay. Right. Can you see my screen?
Yes, I can.
Okay, so I also have an adolescent Blount's case presenting after skeletal maturity. I think he was about 18 years at the time. I'm going to be focusing on the right leg. It looks like there's probably also deformities in the left leg, also pelvic tilt. So there might be some amount of that's apparent. So starting with the mechanical axis deviation, we can see that the mechanical axis of the limb is medial to the joint line, and measuring it, it's quite a bit, about 11 centimeters, 11.5 centimeters. So overall, we have a varus deformity. So then drawing the mechanical axes and measuring the mechanical axes of the bones, we can see that the distal femur has a lateral distal femoral mechanical angle of 104 degrees, which is too much, and greater than the 87, it's meant to be the medial proximal tibia is 78 degrees, it should be 87, and the lateral distal tibial angle is 78 degrees, it should be 87 degrees. I originally drew it with anatomical planning, so you can actually see both on that picture. I drew the normal anatomical angles there previously. So clicking on, so from that we can see that we have deformities in the distal femur, proximal tibia, and distal tibia. So that's just same pic. So then we're going to go on to finding the apex. So to find the apex, I used the anatomical axes of both. So for the femur, it was fairly straightforward, where the proximal and distal anatomical axes met. That was the apex. For the tibia, more difficult. They don't really meet in the bone. So this is the probably two deformities case. So one option is to add a mid-diaphyseal line, which I did there. So using that method, we've got the apex basically at the knee proximally, and the metaphysis distal, tibial metaphysis distally. If you just did mid-axis lines, you get somewhere in the middle, which seems probably not right. So I didn't carry on along that way. Going on, so then planning the possible correction sites. So distal femur, it's possible to do a correction at the apex. So it's possible to do a distal femoral osteotomy there. tibia can't really do a osteotomy at the joint. And we've got the patella tendon to worry about, so it will have to be a bit distal and follow osteotomy rule number 2. And then the distal tibia, it's possible to do one at the apex again. So just sort of rough paper cutouts. So that's just correcting the femoral one, just hinging at the apex there. So it's not like an osteotomy as we'd really do. You can see some improvement in the mechanical axis. If we add the proximal tibia, we get a lot more improvement in the mechanical axis. If we add the distal one, it's still a bit improved, but not a whole lot from the previous one. So I think practically, clinically, for a patient like this, probably the plan would be to correct the biggest deformity first, being the proximal tibia, and can do that probably gradually because it's quite a significant deformity, and then probably do the distal femur and then see what you're left with in terms of patient satisfaction and how far from the mechanical axis the correction is there.
Yeah, perfect. That's brilliant. That basically just illustrated what I showed. So if you go back to that first slide or on that first screen, the key here is that when you do your deformity analysis and tibia, that you see that, yeah, basically the angles are abnormal, but when you try and find the apex, the distal and the proximal line don't intersect, or sometimes they intersect outside the bone. This tells you that there's 2 deformities. So basically, like you say, then you can now also draw an axis of the middle segment, which is the intramedullary line, and then you find that you have 2 apexes. So you can then, so basically you need to do 2 osteotomies to correct this tibia. There is another advanced method. This is now just completely sort of nice to know. It's called the LOCA method, which is the line of closest approach. It's basically a mathematical calculation where you calculate the best place to do a single osteotomy that would correct the alignment overall, but obviously you'll have a slightly Z-shaped tibia. So in some cases where it's close together, like a diaphyseal and the metaphyseal deformity in a single limb, you can use that method to do a single osteotomy. But like in this case, where there really is a distal tibia and a proximal tibia, it would be best to do both. And it's better to stage it. Sometimes you can do one acute and one gradual, and you can do it sort of in one go. Like you can do the distal one acute, fix it in a ring block, and then do the proximal one. The proximal one with a gradual correction. Great. Any questions for Francis? Yeah, no, great. Yeah, that's very well. Yeah, and it's good practice. So just unshare your screen quickly, Francis. Then I'll just end up. I don't know if anyone have any questions. So to just show you how complex it can be, let me share the second screen. So this is well, it's not a child anymore, but an adolescent with a skeletal dysplasia that's had multiple sort of surgeries that didn't go so well. And there you can see his legs. If you look at the right leg, which has a very, very obvious multiple deformities, but you draw a mechanical axis, you know, it goes through the middle of his knee. But obviously, there obviously is just multiple deformities, and the overall result of the result of the deformities are a neutral axis. It can sometimes be in your benefit. So with him, you know, his right side actually had quite a stiff knee, and the leg was just really a stiff peg to walk on. But his left knee had a very bad valgus, as you can see there. And so for him, I did a frame, short stature, so he's an adult, but only about 1 meter high, and corrected his deformities so that he has a straight, good leg on the left now, and then the stiff, overall straight leg on the right side. Let me share this screen. There's a groot, that was a private case, a groot case where you can see here, this is a well, child, but now also an adult that had a physial abnormality, so multiple physial bar excisions as a young child, but didn't follow up very well. So you can again see on the left-hand side.
Prof, we can't see the screen.
Maritz.
You can't see my screen. Can you see a screen? Sorry, let me just try again. Oh, okay, sorry. Okay, great. So you can see here it's a little markers from attempted physial excisions child. So on the left side, if I do the deformation there, you can see there is a deformity in the distal femur and the tibial deformity. Some valgus in the femur have various, some valgus in the tibia have various in the femur, but overall a slight valgus deformity, not too bad in a sort of low demand patient, but obviously on the right hand side, a very S-shaped leg. But again, the mechanical axis is not that grossly abnormal, but you can see the joint line is almost 70 degrees because there's such a big distal femoral deformity and a proximal tibial deformity. Now, another thing to consider in a case like this, if you do a gradual correction, obviously while you treat the femur, you know, his leg is basically going to point almost horizontal to the one side till you do the femur. So then a consideration would be to do both at the same time, which adds a little bit of complexity. But anyway, so for him, we did a stacked frame, so 2 frames connected at the knee, distal femoral osteotomy and a proximal tibial osteotomy, and then corrected both deformities simultaneous to basically make his knee in a very abnormal leg, his knee joint horizontal. Sorry, I've got too many screens here. Let me just drag here. So to make his knee joint horizontal, so now his axis is still not that much different from how it was, but he's got a horizontal knee joint, and his gait and his knee symptoms is a whole lot better. So I think that's enough. I don't know any questions from anyone. So basically the principles always stays the same, and it's very simple. There is more to it. It can be quite complex, and not all cases fit into the simplified version of deformity analysis, but you know, it's always apply the basics first before you can, you know, progress into the more complex cases where there's often multiple deformities or deformities in more than one plane. Any questions?